Cervical cancer is the 12th most common cancer in women and the most common cancer in women under the age of 35. There are approximately 2,900 new cases of cervical cancer a year. About two-thirds of these women will survive their cancer for more than 5 years, but there are still around 940 deaths from the disease each year. Mortality from cervical cancer is falling, mostly as a result of our screening programme. By taking cervical smears, we can detect cervical cancer at an earlier stage, or indeed the severe precancers, and treat these before they go on to become an advanced cancer. Over 3 million smears are sent each year, mostly by practice nurses and GPs. For the vast majority of women, a smear will bring a reassuring result and an invitation for rescreening in 3 to 5 years. For around 200,000 women every year, the smear will prove to be abnormal. The human papillomavirus is an essential prerequisite for the development of cancer. In the UK, two types, namely types 16 and 18, will account for more than 3/4 of cervical cancers. But this process will take many years, and there are several important steps along the way, giving the body time to mount an immune response and reverse these changes before an individual develops cancer. HPV enters the cervix through cracks in the lining. The virus then uses the cellular machinery to reproduce itself. This action will cause abnormalities in the cells that can be picked up with cervical smears. This is typically termed mild dyskaryosis. Dyskaryosis refers to the appearance of the cell under the microscope. Once dyskaryosis has been identified on a smear, the patient will require a colposcopy and typically has a biopsy so that the abnormality can be accurately graded into one of 3 levels: mild, moderate or severe dysplasia. These levels are also known as CIN, cervical intraepithelial neoplasia, 1, 2 or 3. The grading of biopsies depends on the extent to which the cell changes extend through the lining of the cervix. With CIN1, these changes are typically confined to the bottom third of the lining, whereas at the other end of the scale, severe dysplasia, or CIN3, the changes extend throughout the lining of the cervix. The difference between cancer and CIN3 is that not only are the abnormal cells extending all the way through the lining, but that they've now begun to breach the basement membrane and extend into tissue spaces where they should not exist. Cervical cancer itself is divided into 4 stages. In stage 1, the disease is confined to the cervix. This stage can be further subdivided into disease identified under the microscope and disease that is visible to the naked eye. In stage 2, the disease has moved just off the cervix, either to the parametrium, which is the tissue surrounding the cervix, or to the upper vagina. Stage 3 disease has progressed even further, extending out to the bony side walls of the pelvis or into the lower third of the vagina, whilst in stage 4 disease, the cancer has invaded into adjacent organs such as the bladder or bowel, or there is distant spread to the lungs or liver. For the majority of those women with abnormal smears, the result will be a mild abnormality. Previously, we've invited these women back for repeat smears or for colposcopy, but it's very difficult to predict who will go on to develop a more severe precancer and indeed a potential cancer in the future. Recently, we're using HPV testing to try and reassure us as to those women who are at low risk of progression. HPV testing is very sensitive. For those who are high-risk HPV positive, a referral to the colposcopy clinic will be required. In the colposcopy clinic, the cervix will be examined with a type of microscope called a colposcope, using stains to identify areas of abnormality. If an area of abnormality is seen, then it will typically be biopsied. Patients with CIN1 lesions are often managed conservatively and may be followed up back in colposcopy or with a smear in a year's time. The majority of patients with CIN2 or 3 lesions will require treatment. During treatment, the area of affected cervix is typically removed under local anaesthetic. These sort of treatments are often referred to as a LETS, or large loop excision. The LETS procedure is a very effective way of treating CIN2 and 3. Women who've had the procedure will typically be seen back for a smear and high-risk HPV testing at 6 months. For those women identified as having cancer, either on the biopsy or appearances seen in the colposcopy clinic, the treatment will depend on the stage of the disease. Most cervical cancers arise from the squamous cells, and these are particularly sensitive to radiotherapy. In fact, radiation treatment could be used to treat all stages of cervical cancer. Recent work has shown that the addition of chemotherapy to the radiation schedule can improve response rates. However, radiation will affect all tissues that are within the treatment field. In those women with early stage cervical cancer, that's to say stages 1 and 2A, treatment can be effectively delivered using surgery. This provides an opportunity to avoid the side effects associated with radiation. For stage 1 disease, that's to say cancers confined to the cervix, the extent of the surgery will depend on the size of the disease. For the earliest stage of cervical cancer, that's stage 1A1, or microscopic cancer of small dimensions, the treatment can be quite simple, taking the form of a loop treatment or a cone biopsy, often in the clinic setting. If a patient has completed her family, then she may elect for simple hysterectomy at this stage. For the larger microscopic lesions, that's stage 1A2, surgery needs to be more radical and is classically being delivered by the use of the radical hysterectomy and pelvic lymphadenectomy. The term radical hysterectomy implies that a bigger safety margin will be removed around the cervix. The pelvic lymphadenectomy, or removal of the lymph nodes that drain the cervix, is designed to assess for the risk of spread of disease, as this has a significant impact on the need for additional treatment and indeed survival. For stage 1B disease, that's to say visible cancer or large lesions confined to the cervix, the most common treatment is surgery in the form of a radical hysterectomy and pelvic lymphadenectomy. For some women who are deemed unfit for this procedure, chemoradiation or radiation therapy provides a viable alternative. For women who have a strong desire to preserve their fertility, the operation of radical trachelectomy now exists. In this procedure, the cervix is removed along with the safety margin of tissue from around the cervix, but the main body of the womb is left in place. Radical trachelectomy is typically combined with a pelvic lymphadenectomy to assess for evidence of disease spread. It's hoped that in forthcoming years we'll be able to inject some dye around the cervical cancer and to accurately identify the lymph node or nodes that the cancer may have spread to. By confining our surgery to the removal of just these nodes rather than the entire lymph node basin, we hope to be able to get accurate staging information, but to reduce the side effects for that patient. For larger tumours, that's to say stage 2B to 4A disease, the most effective treatment is radiation or radiation combined with chemotherapy. Modern radiotherapy techniques are being developed and used to reduce the impact of radiotherapy on those patients undergoing treatment. Surgery has a limited role in the treatment of advanced cancer. It may be used where the disease has resulted in a false passage connecting either the bladder or bowel to the vagina, or in cases where there are large lymph nodes that may not respond well to radiotherapy. For patients with early stage cervical cancer, treatment is very effective. Patients with stage 1 disease have excellent outcomes, with 90 to 95% of patients being free from disease at around 5 years. For those with more advanced local disease in stage 2, this falls to around 70%. Even for those patients who have locally advanced cervical cancer, chemoradiation can result in as many as 1 in 5 patients surviving to 5 years.